All right, well, welcome everyone to what I think is going to be a fascinating talk today by Dr. Reid Robison from the US. Before I introduce Reid more formally, just want to say a few words about what we're doing so that people can clearly understand the mandate and focus of Mind Medicine Australia. All right, well, hopefully you can all see that on your screen. I'll go through this like at pace, but there is a lot happening in Australia at the moment, as you'll all appreciate, given the TGA's decision in February. Okay, I mean, the reason behind why Mind Medicine Australia started 4.5 years ago is simply this, that as all of you will know, we have what I think can only be described as a mental health epidemic now in Australia, and it seems to be getting worse. 1 in 5 pre-COVID with a mental illness, extensive uses of antidepressants amongst not only adults, but also now children, massive costs in terms of human potential and cost to society. And generally speaking, before that decision in February from the TGA, the tendency of governments and peak bodies was really to look at incremental change. And the problem with incremental change is that you don't solve an epidemic by incremental change. Elephant in the room, which we've talked about before, is that when you look at current treatments, they work with some people, but they don't work or work effectively with a significant number of people. People in particular who come into the treatment-resistant camp, but also people who get some sort of positive response, but they don't actually go into remission. High relapse rates, as I say, extensive use of pharmaceuticals, with depression only about 35% going into remission with current treatments. With PTSD, the clinicians tell me that it's probably not much better than 10%. High relapse rates even when people do react favorably. With other mental illnesses like anorexia, massive problems in our society, particularly with young people. With drug addiction, high relapse rates, and so it goes on. Now, I just want to emphasize very strongly that we are in awe of our frontline clinicians. We think you do an extraordinary job, but the problem is that in our view, you have inadequate tools. And if we can broaden the range of treatment options available to you, hopefully we'll see much higher remission rates in the future. Purpose of Mind Medicine is simply this: to broaden the treatment paradigm in Australia so that clinicians have more options with their patients. We have zero interest in getting between the patient and the medical practitioner. That relationship for us is, and the therapist, those relationships for us are sacrosanct. All we're focused on is broadening the treatment paradigm. And again, where we focus on broadening the treatment paradigm, it's the use of treatments that have been shown to be effective in trials and have been shown to be safe when used properly with appropriate protocols. We want new treatments, and we're focused on psychedelics simply because they're way ahead of other prospective treatments in terms of creating a potential paradigm shift in the treatment options and effectiveness of treatments. We want to see psychedelic medicines as an integral part of our mental health system. We want to see higher remission rates so that those statistics I quoted up front start to become a lot better. And really importantly, we want psychedelic-assisted therapies to be accessible and affordable for all Australians in need. In terms of what we do, there's 4 core components to our strategy. It's all about building the ecosystem for these new therapies in Australia. The first component is awareness building and knowledge, and our webinar series is very much a part of that. It's bringing experts from around the world to talk about what they're doing in the psychedelic therapy area. But we also are constantly out there talking to stakeholders, psychiatrists, psychologists, psychotherapists, regulators, politicians, to get them up the curve about just how prospective these therapies are. The second area is professional development. We've currently trained about 240 clinicians in the use of these therapies. We're going to be training a further 100 from July of this year. I'll talk a bit about that very shortly. And when you look at our course, it is the only comprehensive course in Australia focused on MDMA, psilocybin, and ketamine. We work very closely with the university sector. We were the organisation behind the $15 million grant round from the Commonwealth Government, which I think is still the largest government grant round in the world. We were behind the Neuromedicines Discovery Centre at Monash University to research the molecules. We're currently funding 2 psychedelic trials, one of which is a healthy person's trial. The other one is an OCD trial. And we're also focused on economic analysis and making sure that these therapies become a natural part of the education system with health sector courses at our universities. And the last area is obviously patient access. And after 3.5 years of hard work and an extensive campaign where many of you were involved, we saw the TGA reschedule these medicines effective from July 1, which is very exciting. We're now focused on medicine supply, clinic rollouts, cost effectiveness, accessibility, and so forth, to really be true to our objective of making sure these therapies are available in medically controlled environments, but at a cost that is accessible by all Australians, not just wealthy Australians. That rescheduling decision, I think, shocked a lot of people because Australia doesn't tend to lead on these sorts of things. But, to the credit of the TGA and the Australian government, we did see that rescheduling decision in February. The beauty of that rescheduling decision, and I can say firsthand that it's changed the whole psychology behind psychedelic therapies in Australia, because people now see these as medicines. They're Schedule 8 rather than Schedule 9. And that change has meant that there's a lot more credibility in this country and a much increasing awareness of these medicines and what's been achieved in overseas trials. But with the leadership which Australia has now got, that puts on us a heavy onus to get this right and make sure the therapies are done properly by trained clinicians in medically controlled environments who take the learnings from clinical trials from around the world. In terms of the rescheduling, as I'm sure you all know, only psychiatrists will be able to prescribe psilocybin and MDMA as part of therapy. They'll only be able to do it in the case of psilocybin, for treatment-resistant depression, and in the case of MDMA for post-traumatic stress disorder, treatment-resistant. But in both cases, there's a huge number of patients that can take advantage of this. Psychiatrists have to become authorised prescribers, which means they have to apply to an ethics committee. And we actually see that as a good thing, because it means that we're going to have psychiatrists who have to justify the fact that they are properly trained and they have got the right protocols in place. That brings me on to the right training. And again, I just want to emphasise to all the clinicians on this call, the Certificate in Psychedelic Assisted Therapies, which we started 2.5 years ago, as I mentioned, has trained 240 clinicians to date. We have another intake on the 1st of July. It'll be limited to about 100 in 2 intakes of 50 each. The first intake is now full. The second intake is filling fast. So if you are interested, please get in contact with us sooner rather than later. There are also scholarships available for those who are financially disadvantaged. And the reason we have those scholarships available is we want the best people coming into this course. So we have the best people actually practicing these therapies post July 1. The international faculty is extraordinary, and you can see some of the names there. But we really do have many of the leading experts from around the world who will be teaching on this course. And you can see people there like Geeta Vaid from New York, Ben Sessa from the UK, Ellie Costello, a leading trauma psychiatrist from Australia, David Nutt, Rick Doblin, and so it goes on. So you really will be getting the very best training if you come onto the course. The course is a combination of interactive webinars and a 1 week residential. And during that 1 week residential, we'll be using holotropic breathing as a way of better understanding altered states. But as I mentioned before, there is a healthy persons trial that's about to get underway. And that will mean that graduates of the course will be able to apply to be part of that trial. And that will give them experience in the clinical environment of actually taking either MDMA or psilocybin, which is pretty exciting. David Nutt, who you all know, David Nutt describes our course as, in quotes, the best of its kind in the world. And we've intentionally gone out to create the best course. So that was wonderful when David acknowledged that. But as I say, if you want to be part of this course, please contact us sooner rather than later, because we will be closing applications in about 3 weeks. Last point I just want to emphasize, and that is that we are a charity. We are avowedly not-for-profit. We have no vested interests. We just want to see more patients go into remission and get out of the sector. And we want to see clinicians having more tools available to offer to their patients. How can you help? Well, firstly, if you're a clinician, do the course so that you're available to be therapists or psychiatrists involved with these therapies when they become legal after the 1st of July. Talk to everyone you come in contact with about these therapies. So we build awareness, donate and fundraise if you're able, and volunteer if you're able. And particularly if you're a clinician, that volunteering is very, very helpful to us. Last point I want to make is that we really do need to create a sense of urgency. For too long, we've accepted the fact that too many people who get mentally ill aren't getting treatments which get them out of the mental health system. And it's getting worse. And we now need a real sense of urgency to create the right sort of momentum to enable these therapies to be used safely and effectively in clinical environments. All right, so without ado, I'm now delighted to be able to welcome back Dr. Reid Robison. Reid last year spoke to us about his work with psychedelic assisted therapy in the treatment of eating disorders, which is obviously a really challenging area. He's that rare combination of practicing American psychiatrist, researcher, and medical entrepreneur. Importantly for us, he's done lots of research, and he's got lots of research experience and clinical experience with psychedelic medicines. He was an early adopter of ketamine-assisted therapy and the use of Spravato or esketamine. And he was a coordinating investigator of a MAPS MDMA assisted therapy trial for eating disorders. He's currently medical director of an eating disorder center in Utah called the Center for Change, and he's chief clinical officer of Numinous, a for-profit company in North America focused on psychedelic research and treatments. He's also led health initiatives on trips to poorer nations and refugee camps. And if that wasn't enough, he's also set up a number of psychiatric clinics. So Reid, we're delighted to have you on this webinar with us. So welcome back, and I might pass over to you. And please raise any questions you have of Reid in the chat, and I'm sure Reid will endeavour to answer as many of them as possible in the time that we have available.
Thank you, Peter, and thank you all for joining. It's really an honor to be here. I love any excuse I can get to interact with the mind medicine community. It's just been a joy in the annual conferences and webinar series, and I especially like the question and answer. So I'm going to try and keep the slides to a minimum, but I'll go ahead and share my screen here. And I'm excited to talk to you about ketamine. It's been a big part of my work for quite some time. Here we go. There we are. And the title's a little different on my slide deck. Today I was thinking I'm not really counting the number of ketamine doses. I picked a conservative number, and I thought it made a an interesting title at first, but I'll talk about how I got into working with ketamine. I had finished residency training in psychiatry around 2009, and I took a job doing clinical trials at a university, the University of Utah, studying new medicines because I was already getting discouraged with what was available and the response rates. And the studies coming along just seemed to be Me Too drugs, like an extended release of something that was already there, or a slightly modified antidepressant. And I'd been watching the literature. I knew of the ketamine study at the NIH and the one at Yale. But then I was starting to design and propose my own study. But then I was asked by Janssen and Johnson to do an IV ketamine study. And so I said, of course, and got to sit with dozens of people during their ketamine experience as they received an infusion. And there was no therapy tied to this study. It was for treatment-resistant depression as a medicine. And I'll talk about the differences. But I got really interested in the experience that happened because I actually had to ask questions before, during, and after using the dissociative state scale. If you're familiar with the CADS, it has questions like, what is happening to colors, or is time speeding up or slowing down? And I just got fascinated with the psychedelic properties of ketamine and what we might be able to do with that state of consciousness, and what kind of therapy modalities might pair with it, in addition to the fact that it was a rapid antidepressant with anti-suicidality properties. So I did that study, got a grant, and even set up an infusion practice at the biggest hospital here in Utah, where people would come in once or twice a week who had tried ECT or had vagal nerve stimulators implanted, tried every medicine, and we got to see some incredible results. What was interesting was sometimes the clients coming in, we borrowed space in the cancer center where people would come in and get their chemotherapy. They gave us a couple bays for ketamine. And at first we were borrowing nursing support, but they got a little uncomfortable. They're like, your clients are crying and we don't really know what to do with it. Or so we started working a little more on the set and setting and the support around it. And it just kind of expanded from there. I took a bit of a sabbatical and away from like academic and big hospital work, really spent some time in an eating disorder center. But then I saw what was happening here in the US. Clinics were popping up that were just ketamine infusion centers without any mental health practitioners there. And there are, in the state of Utah, not the biggest state in the US, there are probably dozens of ketamine clinics. And some are places you just go in and you get your dose of ketamine, but there are no therapists or no psychiatrists. I was even at the grocery store the other day. I look over, there's a pharmacy in the strip mall, and then next to it, I see a sign that says now offering ketamine infusions. And so it's kind of the Wild West out here in terms of ketamine treatments. So I like to talk about like lessons learned. And while yes, this is a safe medicine, there are some important considerations in terms of screening, evaluation, and psychosocial and mental health support to surround it with. And a really important opportunity we have when we give someone ketamine, not only during that experience, but before and after, to help them work on their mental health. And so what I'll do is kind of talk about some of the history, first of all, where ketamine, interestingly, was made because PCP, known as angel dust on the street, was actually an anesthetic at first, but people came out of that quite agitated. So there was this hurried race to find a better anesthetic, and they landed on ketamine that didn't leave people so agitated coming out of it. And what's interesting is that the term psychonaut that we like to use in the psychedelic field was actually coined by someone referring to ketamine. You know, psychonauts were known to seek these altered states of consciousness. And then here's just another little fun fact. I'm sure many of you are familiar with John Lilly, but there are some wild stories out there about one of the early psychonauts who did actually a lot of early work, research, and self-exploration with ketamine. He's an interesting fella who became a physician and is a really controversial character because he said something like, "My body is a crash test dummy." He self-experimented. He actually invented the sensory deprivation tank by bringing the sensory external stimuli down to nil. He found that he could bring about or occasion an altered state of consciousness or out-of-body type experiences. He was one who was in this slide. I have a story here where he took ketamine, and this is very much not recommended, but he took ketamine and was in a dolphin tank and had this really profound transformative experience of like the sound that dolphins made and what it felt like when he was on this medicine in there. So anyway, lots of infinite rabbit holes you could go into, but ketamine, I just wanted to point this out because ketamine, some people think of as more of a recent addition to the psychedelic medicine class, but it actually has been around and used by explorers of consciousness for quite some time. As you can see, like even in the 1970s, there were books written like Journeys into the Bright World by Marcia Moore, talking about ketamine as a psychedelic, for example. And even before I was asked to do that depression study, well, this is up here for no reason. I just thought it was fun, but I can't even interpret it myself on what this really means. But here's the family tree of psychedelic type medicines, including ketamine. But before I even did a ketamine for depression study, before I was involved in a clinical trial that was using ketamine to bring about a state of a psychotic type state, where then we would test antipsychotic medications. Not a perfect model of psychosis, but it does, like you could say about many psychedelics, especially classic ones, it does bring about psychotic type symptoms that we don't often call psychosis because it's temporary. But if you look at how you bring about psychosis in the brain, we were talking about PCP earlier. That's more of an agitated one, but if someone takes a lot of methamphetamine, there's so much dopamine activation that there is a delusional state that can occur. There are mostly auditory, some mixed hallucinations that come about. If you take a classic psychedelic, as we know, that flood of serotonin release brings about more of a mystical state of consciousness that happens to bring insight with it. With ketamine, you don't have across the board, and it's there's a lot of individual variants, but you don't have as much built-in insight as you do with the high-dose psilocybin. Ketamine can still be a profound mystical experience. It can still be the state of consciousness where someone downloads some of the most meaningful insights in their life. But on average, across big numbers of people, I would say, and there are probably lots of opinions on this, I would say that you have to work a little harder as a therapist to help people make sense of it. One of the most common things I hear from people coming out of ketamine, and I gave ketamine to a group of 6 people today, for example, in a 6-week 3-dose program of ketamine plus internal family systems therapy that I'm doing with my co-therapist. And coming out of that, people, I think, fairly commonly will say that was strange or weird or whoa, they don't even know how to describe it. But I just wanted to point out these different pathways. And then here's another interesting graph out of Gould Dolan's lab. She is doing some really important work on critical periods, especially critical periods of social learning that are opened up, like that psychedelics can be the key to that unlocks this critical period of more malleability and learning. In fact, she was just on the Tim Ferriss podcast a couple of weeks ago. If you haven't listened and want to soak up some good content about her work, go check that out. But interestingly, there's some correlation with half-life of psychedelic medicine and duration of this neuroplasticity critical period that opens up that you can really use to make meaningful change in therapy. And this is early in terms of the understanding, but as an aside, Gould Dolan's group was the group who did the octopus MDMA study that Rick Doblin likes to talk about. I don't know if he spoke of it the other day with your group, but there were these octopuses in a tank and they're not very social creatures. They can be quite mean, and researchers sprinkled in MDMA and they became quite affectionate, social, and cuddly even, which is just it was a fascinating study. But so this is what piqued my interest as a psychiatrist doing clinical trials is along comes a rapid antidepressant that has a response rate quite a bit better than treatment as usual. And then since then, besides anesthesia and besides chronic pain that's been around in the ketamine use list for quite some time, the list of mental health conditions that are amenable to ketamine has been expanding. And here's one big study, just I'll point out briefly, is a meta-analysis of 9,000 ketamine infusions. This is not ketamine-assisted therapy, but a response rate of over 50% with just giving the medicine as a drug, not to mention what you might do with some psychotherapy on top of that is pretty good. I mean, that's sure, there's some people still suffering, but the majority of people responding to a non-daily treatment is quite promising. So a little bit on how ketamine works. And I've broken it down into a few different ways and given an analogy for each, because ketamine has, I'd say, somewhat of a complicated mechanism. It's not a simple matter of saying it's glutamatergic. I mean, yes, it does restore glutamate or glutamate signaling, glutamatergic tone, kind of like you're jump-starting a car battery. In depression, I don't have the graph, here it is. In a depressed state, the areas of the brain can be underactive. And here's a PET scan showing less activity in certain areas, less blood flow in certain areas in depression, and then when in remission or when less depressed. And ketamine is like you're jump starting some of those pathways. Another way it works is there's this little part of the brain we don't talk about much called the lateral habenula, back there somewhere, and it can get in what's called burst mode, or this is the anti-reward center. So the opposite of feel good. It's like a stress center. And in modern life, for so many of us, it can get kind of stuck in this. And ketamine, it's like you're taking a fire extinguisher to that or hitting the reboot button on it. And it is one of the reasons I think that people come out of a ketamine session feeling lighter, feeling like a cloud is lifted. In fact, one of these participants after ketamine today in this group setting said, does anyone else feel this ketamine afterglow? And someone else is like, yeah, I feel like I've got love and light spilling out of me again that I did not have yesterday. And someone else is saying, well, yeah, I feel remarkably better than I did, coming into this. It's not always the case, but that is one of the reasons, one of the kind of themes that can emerge, and one of the reasons why I like working with ketamine. So as the Gould-Olin graph showed, there is this malleability or neuroplasticity window that opens up, and it's shorter on ketamine, which is why tomorrow I'm having all 6 of these group members come in for a 2-hour integration session together, where we'll work on this. We'll work on making sense of this, weaving these insights from their journey into day-to-day life, while the brain is more open to learning and laying down new patterns. There's more self-awareness and less of that, heaviness or dark cloud. So last thing I'll mention is someone else said after their ketamine today that I felt like during and after the ketamine session, my brain wasn't bouncing around from so many thoughts and rapidly thinking. And, we can get caught, as we all know, in negative thought loops, rumination, and in depression and OCD and so many conditions, anxiety. This can be quite debilitating. But because of how ketamine works with, this cortical limbic interruption and some calcium channel activity, it slows down your rate of thinking. And in fact, the higher the dose, the slower your thoughts. And there's even a study of sheep where it's almost like you're flatlining a certain EEG parameter by giving a high dose of ketamine, or why a K-hole is how some people describe going into that place of emptiness. And this can be quite useful for someone who is stuck in a ruminative type of mind, to have a timeout, and that can linger afterwards. So, all right, let's see how we're doing on time. I'll talk about the ways that we use ketamine in clinic. So a few years ago, I felt the call to, I didn't finish that story, is that because these clinics were popping up offering ketamine only and not even therapy, I thought, okay, I should leave my comfortable daily rhythm of the work I was doing and what I was learning, and start something up. I started a clinic in a little town in Utah that called Springville with a colleague, and we built it, got a dozen or so clinicians to work with us, had 4 ketamine treatment areas and monitored, private ones, but monitored by this nurses station, and a bunch of individual treatment rooms where we could do individual ketamine or regular therapy, med management, and filled that up within months because of the demand. We took insurance, we priced things really affordably, and we worked with ketamine in these ways, either as a psychedelic where we give eye shades, headphones, the individual lays back in a recliner, we'll give an injection usually, or an IV, or a nasal spray lozenge. We can talk about that in the questions, but my preferred method is by injection, and like somewhere between 0.5 milligram per kilogram to 1 milligram per kilogram. And then they go on a journey for about 45 minutes, an hour. And we set an intention before, we've done some preparation sessions. We talk about it after, we bring them back for an integration session the next day, the next week. We might do a series of these. It looks a lot like a course of MDMA or psilocybin therapy in terms of the structure. Sometimes we use ketamine as a psycholytic. Like before going into your therapy session, we'll give someone a lozenge, maybe 100 milligrams, 150, 200 milligrams. They let it dissolve under their tongue. They walk into the therapist's office and they're more open. They might do any kind of therapy modality. It could be anything from EMDR to parts work to emotion focused deep dive, but your walls come down. And so one thing I wanted to point out, let me see if I can oops, give an analogy for this. So you had Rick Doblin recently talk about MDMA, and MDMA is like the ultimate bulletproof vest to put on while doing trauma work. So say trauma, if we're using an analogy, that it's like you had something tragic happen, like some event, some explosion, metaphorically or literally, where you lost a part of yourself, and you need to, as part of your healing journey, go back and heal it, reclaim it. But this is dangerous territory. Without the help of, a hell of a lot of therapy or these medicine plus therapy interventions, it can feel completely overwhelming, even inaccessible at times. With MDMA, you might put on this bulletproof vest, just walk in there without fear, take it back, face the trauma, go through it, come out to the other side. With ketamine, I kind of see it more like you're putting, instead of a bulletproof vest on, you're putting some distance between you and the trauma. And you're flying over it in a helicopter, and you've got a grappling hook, and you're throwing something at that lost part of you and trying to catch it. And it takes some skill, it takes some practice. It might take more sessions than with MDMA. And it might take some really good intentions, even some serendipity perhaps, but because of this dissociative distance from you and the trauma, you can go there, you can face it. So the other way we use ketamine is psychiatric purposes, as a medicine that helps you in a time of crisis, like a serious depression episode, suicidality. Spravato, S-ketamine, was approved in the US in 2019 as a nasal spray. And we decided in our clinics, by this time we had few clinics. Now we have like 10 or so as part of Numinous, but we had a few clinics and decided, okay, we have the ketamine infrastructure. We've kept prices as low as we can, but people still usually have to pay for it. Their insurance won't. This got approved. It'll probably get covered by insurance. No one knows how yet. Let's just do it. We'll offer both. And since that time in Utah, we've given probably 20,000 doses of Spravato, and every single one of them covered mostly by health insurance. And that Spravato, if you ask most clinicians, they don't love Spravato compared to ketamine because it's only nasal spray. It's only these few doses. There's a very strict dose cap. It's very tightly regulated, in office only, but it's FDA approved. Insurance will cover it. That means people will access it. And we've analyzed our data. We've published it, that Spravato does about as well as ketamine because it's accessible, because it's predictable, protocolized. This is just looking at them as medicines, not paired with therapy. And there's a lot to understand, but there's a debate going on about Spravato, and some countries just like, whether it's like the UK or Canada, don't really make it available, especially with socialized medicine. But in the US, it's been a very helpful tool for thousands of clients because it's been covered by insurance, and people who couldn't otherwise have been able to access it. So let's see. I wanted to talk about a little bit of like how we work with ketamine in terms of intention setting. This is just a little bit of a tangent, but I like to look at intentions as like the loosely held hope, or a seed you plant in this fertile state of consciousness, and then give it the right conditions and let it grow, or some kind of anchor you can reach for when you're kind of blown around in this wild journey of a psychedelic experience, and that you can tie some meaning making to. So in case it's helpful for you, here's a formula that when some people get lost in, like, lost in the process and want it broken down into, say, like a mathematical formula, this is one approach you could take with them, is like, choose one of these verbs. Help me with blank. Teach me about blank. Show me blank. So, and what the blank could be is like a difficult emotion. Help me understand my anger. Teach me about my guilt or sadness, or show me how to embody more like love, compassion, some essential quality. Help me experience joy, or understand what's in the way of that. And then a couple other tips for navigating a ketamine journey that you could apply to other psychedelic medicines is, some people end up overthinking, like when they're even under the influence of a medicine, even though ketamine can create spaciousness. There was another participant today who I kind of suspected this might happen because everyone else had eye shades on. She didn't. She put them up and was looking outside. And I knew she was prone to distraction from the last time, came out rather early, but she was so caught up in hoping it's a good one, expecting it to be deep and last long and fix XYZ, that and admitted this after, is that the overthinking during kind of pulled her out of it. So instead of following those thought loops, one thing I'll sometimes do with people is have them like drop into a bodily sensation or feeling. Like, what are you feeling? Leaning into that, and ignoring the content of the thoughts and focusing instead on what you're feeling. Or you might come back to your intention. You might, if something weird, scary shows up, you might ask, why are you in my mind? Or get curious without thinking about it too much. You might just come back to a mantra like let go, trust, surrender. So let's see how we're doing on time. A little bit, I'll fly through these because I don't want to put anyone to sleep with too much boring data, but this is some work we did looking at our clinic data, comparing cost effectiveness of Spravato, which gets criticized for its high cost because it's a newly approved medicine made by Janssen, and their patent protection makes it quite expensive in the US. But even so, it's turned out to be a cost-effective strategy. We looked back at our intramuscular ketamine data and saw some reductions in suicidality. We published, both of these papers in the last several months. Reductions in depression, reductions in anxiety. We did a pilot program where we brought some healthcare workers coming out of the pandemic who were working on the front lines in some way, ER, ICU, even therapists. And we did a 6-week ketamine group, kind of like I'm doing now, but the one I'm doing now isn't for healthcare workers. This is for healthcare workers with burnout, stress, trauma. And we recruited based on a high burnout score. That's the CBI. We measured it after. It came down quite a bit. PCL5, a self-report trauma score, cut in half. PHQ-9, cut in half. Anxiety reduced. We measured mystical experience scores, emotional breakthrough inventory, and with a 6-week cohort, a 6-week, 6-person group with 3 ketamine doses, it was quite affordable. We didn't charge anyone for this, but the way we price our ketamine groups is like, I think our participants right now leverage some of their health insurance and pay some out of pocket. It's less than like $1,000 for the whole 6-week program with 3 ketamine doses. So not only is it, quite affordable, it's also, in my opinion, I like working with groups even more than individuals because there's so much power in the cohort and going through it with another and seeing other people's struggles. And we can talk a little bit more about that. But this is a group ketamine program we did at an eating disorder center that I've reported on in past webinars here. Another couple ways that I like to work with ketamine, and then I'll wind down pretty soon, is families. Like sometimes we'll bring in parents and an adult kid or a teen and give the whole family ketamine because, even if it's a parent or the teenager who have the mental health diagnosis, we're finding that there's so much burden on the family and so much of a struggle that shows up in the whole family. We only give ketamine if there's a diagnosis we can put of record for every individual who gets it. But that's really not hard in our world in these days, especially when there's a significant mental health struggle in the family. So we'll do it in a couple ways. We can, the one I was just talking about is where all the family members, like parents and a kid, adult kid or teen, are getting ketamine and doing it in parallel. And we're doing some sessions together, some individually. Sometimes when that doesn't make sense to do, we'll still have a spouse or a parent or caregiver involved and supporting. Like even if they're not present in the room during ketamine, we talk about, if that makes sense and if everyone's comfortable with it, but just being there as their support through this and empowering them with tools to help communicate and support while at home we found just goes a long way. Even in the MAPS eating disorder study that was mentioned with MDMA that I was involved in, we brought in some caregiver involvement as part of the sessions because there's it's just something that can be so powerful. So sometimes we'll do this in a compressed format, like people might fly into town and get this, so get a couple ketamine sessions over the course of a week or less. Sometimes we spread these out, like this group that I'm doing. Here's like a 2-week equivalent. But as I was alluding to, there's so much potential power in groups. I just encourage you as this psychedelic renaissance unfolds, and as we now look at ways of delivering the medicines, as the medicines become more and more available, that we keep in mind the power of supporting others and going through some of these things together, and how they can be agents for social change. They can help us learn to interrelate and help us practice more and more compassion and empathy towards others. But I think, even though I have lots of slides in the appendix, I just wanted to make sure I leave some time for questions, leave ample time, and it's really nice to be here with you. Thanks for listening. I'm looking forward to whatever we discuss here next, but I'll open it up for questions now.
Well, thank you very much, Reid. We've had a number of questions coming through the chat, so I might just sort of lead off on the questions. I guess the first one is actually my question, and that is that in 3-4 years' time, when hopefully psilocybin and MDMA are also registered medicines in America, and you have a patient come in to see you and you've got expertise across the three, just take us through your thought processes in terms of which medicine is appropriate for which type of patient, or which therapy is.
Yeah. No, it's I like this. I like thinking about this, and I'll admit that I don't know the answer. I think I have an opinion, and I think we collectively are getting a better and better sense of how this might work. But say someone is working, I don't know, if someone comes in with a severe trauma history, complex PTSD. If MDMA is available, great. That makes the most sense, the most evidence to support it. But if someone asks, okay, MDMA is not available, what would you do next? Ketamine versus psilocybin, I would pick ketamine. Or ketamine, we're doing an LSD study in clinic in Utah here for generalized anxiety disorder. That's been amazing. I've probably sat in, I think, 7 of those 12-hour sessions by now. And, it's kind of paradoxical, but seeing people like work on their anxiety by facing it head on has been amazing. And, but I wouldn't necessarily pick that classic psychedelic like LSD or psilocybin as first line for trauma if I could approach the trauma first in the algorithm with MDMA or, as a second choice, ketamine, if that makes sense. If I were treating, say, borderline personality disorder, and I wanted to pick the right combination, assuming I could even use 2 of these at once, I might ideally give someone MDMA to surround it in a safe container, and then something like psilocybin, even in the same dosing session or later in the sequence, to dissolve those ego structures, but without worrying as much about what would happen if you haven't done the trauma work or surrounded it in that container. But I see ketamine as a really useful stepping stone to help people get ready for intense higher dose psychedelic experiences. And I see MDMA as an important tool, of course, for helping people heal from trauma on the way to work on the other things that, beyond the healing from trauma, the growth, the working on the other patterns and ways of, attachment, wounds and ways of interrelating and ways we show up in the world. So I know I'm not giving a clear-cut answer, but I think those are some general ways I'd think about it.
It's going to be fascinating. It's going to be a fascinating learning curve, isn't it?
Yeah. It's a great time to be that we're all here and part of this unfolding. And I look forward to these studies where we can come up with these algorithms even more concretely.
One of the things that we keep hearing from the researchers who are doing the trials overseas, particularly with MDMA, is that the adverse effects of MDMA when it's used in a clinical environment are minor. Just talk a bit about adverse effects of ketamine. Are there any that concern you when people go into a clinical environment?
So people used to say, don't give ketamine if there's a history of psychosis or even dissociation. But, I like to challenge that because, yes, ketamine can bring about a psychotic type state. But if you look at the data, and the data is growing, ketamine, if you give to someone who has a history of psychosis or even some mild psychosis on board, or if someone prone to dissociative episodes, they're going to have a more intense ketamine experience, most likely, but that it comes down to baseline for them, just like it does for others. As a general rule, I will say that there have been a couple cases across these thousands where we've given someone ketamine and it has unearthed a manic episode, for example, manic with some psychotic features that we didn't know was there. Or like, I think it's kind of like cannabis for people at risk of psychosis, and it might precipitate or speed up their first break or the emergence of some psychotic type symptoms. But I don't think it's necessarily the cause. And this is also the reason why we surround all our ketamine experiences with a lot of psychosocial support, like mental health support, and making sure we've got caregivers wherever possible. But otherwise, I think some of the other concerns we've had, we've had some concerns where people have come in on a high dose of cannabis already. We didn't know it. Like, they'd had successful ketamine with us before, but then they just smoked a ton of THC beforehand, didn't tell us. And then their ketamine got more kind of weird and chaotic for them, and acting out a little bit. And so you see this with the psilocybin and classic psychedelic literature in surveys of difficult experiences. Some of the predictors of difficult experiences needing some help were the absence of a sober guide and the presence of cannabis in combination with it. So I'm not saying cannabis can't be combined well with a number of medicines. It's just people usually don't know what they're doing with that, and it's not well studied, and there is a chance that it can go badly. Ketamine, like MDMA, causes transient increases in blood pressure, heart rate, comes back down. If you can tolerate exercise, a little bit of exercise, you can tolerate ketamine or MDMA. You can give ketamine more often than MDMA without worrying about neurotransmitter depletion. There is some nausea to keep in mind. Of our 6-person group, the first dose, there was one person who had significant nausea and was even holding an emesis bag, didn't really throw up. But then the second time, with some coaching and keep your eye shades on, move really slow after, take a Zofran before, they were totally fine. So those are some things that come up. And then also a general reminder that, in doing healing work, trauma work, all sorts of mental health work, sometimes you feel worse before you feel better, and it can bring up some content that to the surface and kind of shake things up, and you've really got to be prepared for that. Like, I did a one-on-one session with one of these participants last week because there was a lot coming up in their first ketamine that they didn't even expect. But yeah, so thanks for that question.
Well, there's another one that has been asked by Deanna about ketamine in Australia. And the question had two components. Why wasn't it covered by the TGA in their announcement in February? And why is it not used more commonly in Australia? Well, dealing with the first one first, the reason why it wasn't covered by the TGA is simply because it is Schedule 8 already. And their announcement was all about bringing psilocybin and MDMA from Schedule 9 into Schedule 8. That then leads to the second question, and that is, why isn't it more common in Australia? And I think, a lot of us will have different views on this, but I think one reason is that there is an inertia in the mental health system. And partly that's because clinicians are so busy. But I think the inertia is starting to break down with ketamine. The Royal Australian and New Zealand College of Psychiatrists put out a position paper last July, which was basically positive. And, that institution tends to be incredibly conservative. So the fact that they're now coming out and giving guidance to psychiatrists, I think, is a real positive. How can we all advocate for greater use? I think by making sure we increase awareness in our medical system and our health system about the benefits of ketamine. So webinars like this one are, I think, really important, because each of us can then become an ambassador to get out there and just talk to regulators, politicians, psychiatrists, medical practitioners, and so forth about the benefits of ketamine-assisted therapy, so they actually feel a bit of pressure to go up the learning curve themselves. And I don't mean that in a derogatory way, by the way, because I'm fully aware that our health practitioners are really burdened in terms of time commitment. But this is obviously part of the game changer that we're looking for. Another question, Reid, that's been asked, and that is about toxicity levels with ketamine. Now, obviously, when you provide it in a medical environment, you're below those levels. But how much greater than the current dosing does ketamine become toxic?
And it's a good question, and one that probably requires some some definition of what we mean by toxic, because dose-wise, in psychiatry, we often use like the doses that were studied initially by the NIH, and that got repeated in this depression study I did. It's 0.5 milligram per kilogram IV over 40 minutes. If you give it by injection, like we often do in our clinic, it's still a typical starting dose might be 0.5 milligram per kilogram, or say 25 to 50 milligrams initially. We'll bump it up a little bit as needed, as tolerated, but we're working in this range of like 25 to 100 milligrams of ketamine IM or IV. If you're taking it by lozenge, it's much less bioavailable, or nasal spray. We're giving double, triple those doses. But in anesthesia, the first time I ever gave ketamine was in a children's hospital ER as a trainee, where it was given every day before we would suture kids who came in with a laceration or a fracture that needed to be set. And we would give 4 or 5 times the dose of these. And as we were talking about with the slowing down thoughts, the higher the ketamine dose, the less you remember, and so as you approach this idea of K-hole, like that some people talk about, that might be somewhere in the 100 to 200 and something milligrams if you're giving someone an injection. But like, I don't give doses of 200 milligrams of ketamine because people just won't remember it. Like, would it help their mood? Possibly. It's gonna take a bit longer to come out of it. They might be groggy. But ketamine is so interesting in that you could give even more than that, and it doesn't slow down breathing. It doesn't do, the toxic dose is quite high, and not anything we ever come near in our use in mental health. And anesthesiologists are really good at giving big doses of these things to put someone under for a very predictable time and bring them back. But ketamine, even if someone takes too much, it's not necessarily safe, because they're going to be laying there on the floor of the couch, but they're not slowed down in their breathing, and cardiovascularly they're safe. Even at several times, 5-10 times the dose that we use in clinic. We do sometimes send people home with ketamine if we know them well, if they've really benefited and they can't afford to come in every week and drive an hour or whatever, and we know their caregiver. Sometimes we'll see them every month or 2 or 3, but give them some home doses and some instructions to do that under the support of their loved one. And in the US, that's a controversial, it's a debated topic, because there have been some companies that pop up and just mail you ketamine, and they've never met you, and that's all they do. Like kind of through these pandemic-related telehealth laws that'll probably go away, but that's not the approach we take. But sometimes we do home dosing when it really helps the individual.
Right. And on the other side of that is that we often hear from researchers that if you're on an SSRI, you need to be sort of weaned off it to have the best effect with MDMA and psilocybin therapy. And
Yeah.
One thing that's been put forward is that ketamine can help a patient go through those withdrawal symptoms. Is that a fair comment or not?
I think that's a great comment, a really good point. And I have used it that way. I've used ketamine as a bridge to other treatment interventions of all kinds. And while MDMA is not yet available in the US, and Australia's kind of leading the charge at making this accessible quicker, it's coming, and we're all getting ready for the delivery of that and doing the research studies in the meantime. But I do see ketamine as a very useful tool to help people get ready for a psychedelic experience with MDMA, with psilocybin, with ayahuasca even, and because even though it has a different mechanism, it's a potent antidepressant for many without having to take a daily pill that on average has a duration of antidepressant effect for at least a week or two for people. And so, yeah, I think that's a really good point and a good use to keep in mind.
Yeah. By the way, there's been quite a lot of questions on the chat about who can actually prescribe ketamine in different forms in Australia, and dosages and those sorts of things. So one of the things that we'll undertake to do is we'll work with some researchers to put out a short position paper just answering those questions for those of you who are interested. One thing I did want to say is that one of the comments on the chat was to the effect that MDMA assisted therapy is a long way away in Australia. And I just want to say that's not true. The reasons that were given were, supply. While supply has been sorted, we've actually got secure supplies of GMP psilocybin and GMP MDMA at very low pricing. So the medicines will be available from the 1st of July. The second reason that was given was no psychiatrists with authorized prescriber status. Well, we're actually working with a number of psychiatrists, and they'll be putting in applications shortly to ethics committees. We've done a lot of work in terms of working out which ethics committees will take applications for authorized prescriber status. So we think that's going to happen, and it may be slow to begin with, but it'll then speed up as people see the results. And that brings me to the third thing we're doing, and that is we're also working with some researchers on the development of a registry, so that psychiatrists and patients who go through MDMA and psilocybin therapy actually provide data back to a central registry, which is then put on the website every 3 months or every 6 months in terms of results. So, if the clinical application of these therapies is as good as we've seen it in clinical trials, that will also assist momentum in this country. So I don't think it's going to be very long, and I think we're going to start seeing these therapies being used this year. And as I say, as we start seeing good results and good feedback, then an acceleration, which is exactly what happened with medicinal cannabis. So, and the third reason that was given was cost. There's been a lot of talk about the costs being sort of $25,000, $30,000. That's complete nonsense. It's been pushed by people who have their own agendas. We think the costs are going to be somewhere between $10,000 and $15,000. $10,000 for psilocybin 2 courses, $15,000 for MDMA 3 courses. That's a gross sum, because people who undertake the therapies would normally be spending money on other health programs. So you've got to then bring it down to a net cost. It is still going to be expensive, there's no question, but not as expensive as some people are talking about. How do we bridge the gap? Well, people who are relatively wealthy will be able to afford it, but that shouldn't be good enough for any of us, because we want this to be available to any Australian that needs these therapies. So what we're doing there is we're putting together a patient access fund to help subsidise some patients. We're also going to be advocating very strongly with organisations like DVA and the various health departments, because there will be an equity issue here. We can't have a situation where wealthy people can access these therapies, but poorer people can't. And I think we can play the equity card very hard. So that is uppermost in our minds. Look, I'm conscious of time, Reid, but one of the things that you were talking about, which I found fascinating, was the use of groups, because that's not something that most of the trials to date have really focused on. And I guess my question to you was, when you interface with a patient, what is it that tells you that actually a group is more likely to be beneficial than doing it individually?
Yeah, it's a good question. And at Numinous, where I work with some collaborators in Oregon as well, we've proposed a group MDMA study to MAPS that they're keen on. It's an investigator-initiated one, so we're still working on funding, but we've proposed a group model because this is a study looking at gender minority trauma. So individuals, for example, transgendered individuals with PTSD. And we're challenging the dyad model as well by saying, in this study, we're not going to follow the usual gender conventions of a dyad, male and female. But as we designed this protocol, we had to get really specific about how in trauma work, some things are more amenable to group than others, and some types of trauma combine more appropriately in a group setting than others. Like, for example, we wouldn't assemble a group with combat-related PTSD and complex childhood trauma with sexual abuse. And you can, so that's just one example, but as we're doing groups, like in this group I'm doing right now, we decided to not even pick a diagnosis that we're focused on and say it's all comers for mental health, but we're going to focus on your appropriateness for group, like your ability to, have some kind of emotional self-regulation as you share, your ability to empathize and have some compassion for others, and thinking of the group cohesiveness and the sensitivity of the individual's struggle. And I'll admit there were a couple people who were really terrified of the group model, but really wanting some help and willing to face that fear, who are just thriving in there. And like today in this group, I heard from several different people, I'm so glad we have this group. I'm so glad we get to hear each other's experience. Because I see the healing work we do is in ourselves and in our circles closely, and then we kind of expand it outwards. It's kind of like ripple effects. But to answer your question, there's a kind of an appropriateness for group method coming out of Yalom's work, mostly factors that make people well suited for group that we follow and think about. Yeah.
I should say on that, the Healthy Persons trial that I mentioned, which enables clinicians who've been trained to actually apply to go into a trial for MDMA and psilocybin. One of the things that it's researching is group dynamics, because the medicine will be taken in groups. And I'm going to be fascinating to see and understand how the clinicians rate that when they come out of the experience, because they'll be thinking about the application of these medicines to their patients, and the data it'll be qualitative rather than quantitative data. But I think it's going to be fascinating to hear from clinicians who've actually gone through that experience about the group dynamics and how they see the medicine experience themselves in terms of treatment. But one other thing that I just want to, it's been covered a bit in the chat. People raised this issue of accreditation with the MMA course, Mind Medicine course. There is no course globally other than courses now in Oregon that have been accredited. I think people need to understand this is a new area of medicine, a new area of health sector interventions, and accreditation tends to lag. The second thing I'd say to all of you is that this is not Mind Medicine Australia's course. If you look at the way it's run under the auspices of leading global practitioners. So we've talked about Dr Reid from New York, a New York-based psychiatrist. Ben Sessa, who many of you will have heard from before, a UK-based psychiatrist, and our own Ellie Costeler, an Australian-based psychiatrist. They're the ones who drive the course and work on and determine course content. And then when you look at the composition of the faculty, you've got leading experts from around the world. So, it's very hard to look at that faculty and the competence levels and not have a high level of confidence that it's going to be accepted as a standard in Australia. So we are very confident about that. And accreditation is not required for AP status. So I just thought I'd explain all of that, because this comes up every now and then. And I think it's a misunderstanding of what happens in the early stages of new treatments with new courses. It takes a while for the system to sort of adjust and accreditation to follow, but we are in the course of working on accreditation. Look, somebody else put in there that the scholarships that we provide aren't much. Well, actually, the scholarships cover half the course cost, or can up to half the course cost, so they are substantial. And we do that as a not-for-profit organisation because, as I say, we want to encourage the best into the training. In terms of, I guess, I'm conscious of time, your time, Reid, and you've been very generous with your time. But I wonder, when you look at the future, this is one of those sort of crystal ball gazing questions. When you look into the future and you think about ketamine-assisted therapy done properly, psilocybin-assisted therapy, MDMA-assisted therapy, and that slide that you had about duration of openness, which had ibogaine as the longest in terms of duration, potentially ibogaine, I guess, in the future, although that seems to be a much more challenging psychedelic. But as a psychiatrist, when you look at that coming towards you, how do you see the impact on mental illness and the ability of health practitioners to increase the impact that they have with their own patients?
I'm already seeing the ripple effects. Rewind like 15 years ago when I got out of training or med school, almost 20 years ago, it was not cool to go into psychiatry. We were almost made fun of. Going to therapy was a sign of weakness in the culture, like in my parents' generation. But my kids, two of them already in their teenage years have asked to see a therapist, and that gave me a lot of joy and hope that they brought that up. Even though when they talk about that to my parents are like, "Why did you go to therapy?" But the psychedelic renaissance, I think, is one of the factors driving that and raising awareness of working on our mental health, and one of the conversation starters. I mean, sure, the pandemic exposed a lot of things, and as somewhat of a pressure cooker for our mental health and all these forces at play. But as these things become more and more available, all of a sudden, instead of psychiatrists just grasping at straws, prescribing an SSRI and then a sleeping pill and then a anti-anxiety med, and just these lists getting longer and longer, I think we're able to go more for the cure. Like MDMA data from MAPS, where about 70% coming out the other side of a MDMA course no longer meet criteria for PTSD as a diagnosis, and we're seeing not like MDMA level results, but we're seeing some really promising similar results, as I showed a little bit with ketamine. Ketamine's not going away as a tool. It'll be part of this algorithm. Psilocybin will be part of it, and others. We even have a 5-MeO DMT study coming to clinic this year. It's a really exciting and inspiring time, because of, like, for the first time in a long time, we have new options that go more for the root cause rather than take a Band-Aid approach. So I'm all in on exploring these and opening up access.
Well, that's a great way to finish. I would like just to make the point to everybody on the call that some people raise problems, and it's great to raise a problem, but I think when you raise a problem, there's an obligation to come up with a solution. Otherwise, we never create change. And for the last four and a half years, we have had nothing but problems. But every time what we do is we try and address the problem and overcome it. And because of that, we've now got these medicines being rescheduled. We've now got secure supplies of the medicines available in Australia at very low pricing. We've now got a world-leading course. To all of you, we all want the patients to have the opportunity of going into remission and leading full lives. And we'll only do that if we actually not only identify problems, but also identify solutions and make things happen. So to all those on the chat who keep raising problems, it's fantastic to raise the problems, because we need to identify them, but we also need to come together and solve them, rather than just going around in circles, because otherwise we'll be having this same conversation in 3 years' time, 10 years' time, and it's now time for change. Reid, it's been a real pleasure. It was a pleasure last time, but I wanted to thank you on behalf of everybody for the work that you do, both as a psychiatrist, but also as a researcher, and as somebody who's with your work with Numinous, really trying to push boundaries to see what's possible. It really is a pleasure to meet people like you who are at the forefront and realize that we're in good hands in terms of the leadership of these therapies globally.
Thank you, Peter. Thanks for having me. And thanks for everyone and these beautiful questions. I wish we could get to all of them, but feel free to reach out and look forward to the next time we get together.
All right. And what we'll try to do is we'll try to respond to these questions. And if it's okay with you, Reid, we might attempt a first draft, but then pass it on to you to make sure that what we're saying is correct.
Sure. Sounds great. Yeah, happy to.
All right. Well, thank you very much for everyone who's joined. I'm sure that well, I can see from the chat that everyone's got a lot out of this. And Reid, thank you very much for being part of this. Really appreciate you giving up your time to do this.
Oh, thank you. It's an honor, and hope everyone has a wonderful day. Take care.